of the day. So again, many thanks to the organizers. And this, I was asked to talk about biological treatments for the knee, and in particular, articular cartilage defects. So this is a hospital that I work in. So this is to say that this is what I do. Okay, so this is my practice. These thoughts are my own. So I don't wish to annoy anyone. I don't wish to upset anyone. So if you do something different, and if you practice something I don't practice, then that is fine. This is just, we can debate about it. So just to set the scene. So we know about the Kalgren and Lawrence system. And if we go to his original paper, you can see grade 4 is quite severe. So that's the original paper. But if you look at arthroscopic views, so here I'd say is 1, there we go at 2. Here then is the isolated lesion, E for F. F is widespread arthritis. So I'm not talking about F. Thank you, shukran. So I'm talking about this as grade 2, an isolated lesion up to E, but not grade F. So this is just to clarify what I'm talking about. And again, E is something that I'm talking about as an articular cartilage defect. F, where it's both sides of the joint, that's an arthritic joint, osteotomy, arthroplasty, whatever. So I'm not talking about F. Firstly, injectables. So what I've done is I've just divided this up into the types of injectables that are available to me in the UK. And I think all of these are probably more available in Egypt than they are in the UK from some centres, especially things like PRP. So there's blood products, which is PRP, but PRP is not all the same. PRP can be leukocyte rich or leukocyte poor. And it depends whether you're injecting in the tendons or for cartilage. And the mixtures and the concentrations are very different. And I think that's why the literature is poor, because they put all of PRP into one type. And when commercial companies come, they put all the PRP as they give you a device. They don't tell you what the fractions are going to be. And when you have the machines where you could change the fractions, those machines are very expensive. So we've got to be careful with PRP. PRP is then mixed with all sorts of things, and that's the injectables. I'm talking about orthobiologics. There's non-orthobiologics injectables as well. Cell-based care, tissue transplants, fat transplants, they've had various people who say these are the best things, but most of us don't do it because there's little evidence other than the anti-inflammatory effect. Then there's bone marrow aspirate concentrate and stromal fractions. Again, that some people say works really well. Other people will mix the BMAC or the PRP together with hyaluronic acid. So there's all sorts of variations that go in. And then you do cultured cells. You can either culture MSCs and try and get stem cells and then put cultured cell lines in, or you could get cartilage and you send the cartilage, and I do this. And I'll show you examples where you'll take the cartilage, send the cartilage to the lab grows the cells, and then you put the cells in the defect, and I'll show you pictures of that I've done. I've just quickly through the review of our orthobiologics, there's all these different combinations that people use. So when you actually then try and get any science from it, you could see the numbers are low. If you look at trends, suddenly with the commercial interest, you could see it be relatively flat, and now the numbers of papers that are published are growing up and up and up. But please read the papers carefully. The red is where there's proven bias, The yellow is where there's probable bias, and that's because the company has funded the research. And the green is it's okay. In all these factors, not a single paper there is all green. All the papers have some red and yellow. So this is when we talk about trying to use the literature, we have to even, the companies control a lot of the research and they fund a lot of the papers. And we won't go into the politics of scientific journals, but just look for the conflict of interest. And current guidelines, well, you can see I've done nice, I've got everything across the world. But this can also be biased due to the healthcare economics. So it's not necessarily that it doesn't work. It's just that if you inject it as a healthcare system where things are free, it may not be worth it for the whole group, and it may not be cost effective, but it may work for that individual person, but we can't come and say this will definitely work. And Muhammad Ali said this quote that I actually quite like, that if I think the same way and do everything the same that I did 10 years ago, then it's me that's not learnt. It doesn't mean that I've perfected it. And I hope the day I think I know everything and I know everything perfectly is the day I become dangerous and the day I should retire. So we should be open to new treatments, but we have to evaluate them carefully. Right, so this is why you utilize them. This was really interesting, is that they asked the surgeons, do you use it because you believe in the product, or do you use it because your competitor uses it? So this line is because they're using these things because their competitor is using it, not because they believe in it. And that's from the American science. So you've got to be careful. So essentially, there's no evidence of orthobiologics in grade 3 and 4. Now the non-orthobiologic injectables, hyaluronic acid, again, they're different types, and it costs money, probably doesn't harm, and it provides cushioning for a little while. So if you can afford it, then I think this is fine. But to give everyone with grade 4 arthritis hyaluronic acid would be expensive for a healthcare system. Steroids, good first line, one-off injection for an acute problem, but repeat injections has many problems to the cartilage, diabetes, they could start increasing pain, and if you have an arthroplasty, the infection can go more. Non-steroidals are good, especially rubbing non-steroidals in, works well, no systemic effects, great. Dextrose I have no experience. Patients come and they say they've seen clinics advertise dextrose and ozone. I don't know whether any of the audience has experience of ozone. I've got none, and so I'm going to walk over. Hydrogels, arthrosamid, I've done 150 of them. They're, in my experience, 80% of people are better for at least 5 years. That's the current research that's come out of the 150 I've done, 3 have gone on to have knee replacements. About 10% it doesn't work in, the rest it's working in so far. But it costs £3,000 per injection. So it's a lot of money. Just the injection itself is about £1,200–1,300, but it stays in your knee forever. It doesn't go away. And that's the beauty of it. Hyaluronic acid, again, there's various healthcare systems say various things. Surgical options. Now, this is the cheapest thing, microfracture. And I used to do a lot of microfracture. Used to. I don't do it anymore. And your initial results, if you ever go back, actually you think, oh, you've done well. But under 50s, every single review shows that there's a massive decline in younger people. And then if you've done the microfracture, I can't offer any biological treatments because it's contraindicated. So there's all sorts of reasons why microfracture under 50 is not a good thing to do. So I would say, please don't microfracture under 50s. Over 50s is a different thing, but we all are used to doing microfractures, and I think that's the thing that. But having said that, I have alternatives to give the under 50s, which I'll show you, and all these injections. If you don't have alternatives, then the thing is, do you then do a procedure that means that nothing in the future will work except for an arthroplasty at some time? Or do you do a chondroablation, and lesions under 2 centimeters work well with just a superficial debridement, and then if they have more pain, then you could do an offloading osteotomy. And if something biological, inshallah, will come to Egypt and it becomes more available, you haven't burnt your bridges. So think very, very carefully about doing microfracture for under 50s. Cartilage options, there are 2. But before you restore the cartilage and with cells, you have to restore alignment and you have to restore patellofemoral tracking. Because if you don't, you'll rub your cells off again. It makes no sense. So you must restore alignment, you must restore the rotation, and so there's no point me doing anything biological to that knee. No point whatsoever. So then there's the osteotomy. Now I can do things that are biological because you've restored the alignment. So this is what I was saying. So this is on the BBC iPlayer. I did an osteotomy for all femur, tibia, both legs, all at the same time because I had to for this patient. And then that goes over how I do osteotomies. And again, you've got to get the patella in. So if the patella is all the way out, this is what I was saying before, an MPFL reconstruction, if I try and pull this over with an MPFL reconstruction, it'll hurt them medially and it will fail because the constant drive is the anatomy driving the patella out. So tibiotubercle osteotomy, get the patella back, then I think about biologics. And actually, even we were talking about age before, even in the mid-50s, early 60s, if the patella is really far out, I'll do this first, get the patellofemoral mechanics okay, then I'll do a knee replacement, because otherwise trying to do a knee replacement with the patella coming up is difficult. If they're 70, 80, 90, you accept it. I'm just talking about the younger knee replacement. So ACI, autologous chondrocyte implantation, it's got to be more than 2 centimeters, no previous history of microfracture or anything like that, no osteoarthritis, over 16 and less than 50, so not this patient. So you can see here, this is one of my cases. You debride down to the subchondral bone, and you can see here is where I've taken the cartilage. That then goes to a lab in Germany. They multiply the cells, and then it's called spherox. These little cells are actually chondrocytes. So you could get 7 million cells back. And then you go back in, and then you can see those things all over here. It's called ACI. It's not actually very difficult surgery to do. You just got to know how to clean it. So that's 2-stage. This is a single stage where you have a scaffold. I use Hyalofast. You take bone marrow aspirate concentrate, you spin it down, you inject the Hyalofast with it, and you put it into the defect, and you use Tissil glue all around, and then fibrin glue, and then that's it. Or you put an osteochondral allograft if that all fails, or you can put a metal thing called Episurf. So there's injectables before operation, also biological ones, or non-biological hydrogels, less than 2 centimeters, simple coblation, no microfracture. Over 2 centimeters, then ACI, But if when you get the subchondral bone that's damaged and cystic, nothing's going to grow on that, then we get an allograft with both cartilage and bone, and we plug it into that gap. And that's the osteochondral allograft. Thank you very much. So, do we have any of the rest of the speakers for the session here? Okay, please continue.
السلام عليكم بسم الله والحمد لله والصلاة والسلام على رسول الله. دكتور إبراهيم موجود؟ Before I proceed, may I ask a question, Dr. Amir?
Yes, please.
You said among the contraindications to do ACI is not to have a previous microfracture. Yeah. Why?
Because the results are really bad. So once you've done a microfracture and you've broken... Once you've done a microfracture, from a microfracture you break the subchondral plate.
Yeah.
Once you've broken the subchondral plate, putting a layer of cells over it fails. And we did this when I was working with James Richardson in Oswestry for about 2 years. And then this is over a 10 to 15 year results. So now we're not even funded. So we're funded, it costs we get reimbursed £23,000 per ACI patient. But if they've had any microfracture at any stage, we're not allowed to do the ACI because the results are so bad.
So what you do then?
Then the osteochondral allograft. Because then you're taking the subchondral bone, but doesn't matter anymore. Because you core it out and you put the osteochondral bone.
Yes, thank you very much. Mr. Chairman, thank you very much. Dear colleagues and professors, this is a very short message about saving the meniscus. And before I proceed, I would like to state my conclusion from the very beginning. It's just saving the meniscus, and that we should do and strive every effort to keep the meniscus and save it. When you look at this group of videos I collected from all over my years of practice, this is one patient that you might have it in your practice also with a blood clot over the meniscus, which could be interpreted as a trial or an attempt of healing. Could it be? This is another patient who had this clot or this initial healing attempt with closure of the defect of the vertical tear, and this is another case with this clot which is at the periphery amenable for repairing and closing the defect. That's another patient whom he had this gap closing by some kind of fibrocartilage, probably in some other cases. So probably spontaneous meniscal healing does occur. Based on this, we try to repair our meniscal injuries. And this is also another group of patients for whom we did repair, and then for some reason we did re-scooping to see how eager is the meniscus to heal. So meniscal healing to me is a reality, but it just needs to give the circumstances at which menisci would favor to complete and progress in the process of healing. So that's another patient with a new root tear at the posterior horn of the median meniscus. You can see the tear here. Did a tunnel and we did some repair. I'm not going to talk about the procedure or the technique. And a few months later, we went in for some reason and we found that the meniscus tear is completely healed. This is a tear at the lateral meniscus, vertical one. We proceeded with repair using all-inside technique, and then several months later we went back again for some reason and found that the tear is fully healed. And this is the suture of the fast fix, but the tear is not there. Another patient with a ramp lesion, posterior medial meniscus. This is a ramp. Again, we've done him some refreshment and repair, and like to repair my ramp lesions from the anterior portals. Make sure that the tear is closed, and 7 months later, re-scoping, and we found the tear is completely healed. This is the tear. This is the healing of the tear. So meniscal healing is a reality to my mind. Let's have a look at the literature. Around 80% of the repairs were considered clinically healed because of no additional surgery in this study. Another study, around 75% of repairs, full healing, 10% partial healing. Then the incidence of healing ranges around 75-80%. Then we still have around 1 patient for every 5 patients having trouble with his meniscal repair. So probably 1 in every 5 patients of your meniscal repairs would fail. But if we had this introduction and this reality of meniscal healing, so we might strive to maximize the environment of healing of this remaining 20% of patients somehow. Having a look at this paper, there is a difference, and I think everyone in this room knows this. There is a difference regarding the healing rate in your patients having concomitant ACL reconstructions and patients having isolated meniscal repair. Patients with ACL reconstruction would heal better. So the idea came from here. If you want to maximize the circumstances for meniscal healing, think about the difference between your patients having ACL concurrently done with meniscal repair and patients having meniscal injury and done meniscal repair without having ACL. What's the difference? I think the difference is in the tunnels. So when you do a scope alone or do ACL reconstruction, the major difference is the tunnels. What about the tunnels? The tunnels get some factors, bone marrow, growth factors, which would help in healing of menisci. And this is the simple idea. We went on to study it, and since then we started to prepare to drape the iliac crest in every single patient having a meniscal injury amenable for being repaired and healed, younger age, not degenerative, and so on. We aspirate the BMAC, the bone marrow aspirate, and just injected in the hollowness of the joints and around the meniscal site of the injury after repairing it. This is one case. This is the preoperative, the medial meniscal injury, and this is the video. So this is the tear, the body of the meniscus, and you can note that the capsular side of the tear is vascular enough. So that would encourage you to proceed with your repair. Refresh the edges as we all do. And then you do your technique, your preferred technique of meniscal repair. For me, I like to do outside-in sutures. It's cheap and allows compression and coaptation of the edges, and do sutures as much as I want and as many as I want as well. So doing 1 suture, 2, 3, whatever, until the tear closes satisfactorily. So that's my technique of outside in. 3 sutures were done. And then I inject the bone marrow aspirate simply after having all the fluids out. And for one reason, we rescoped this patient, and you will find what happened to this tear. This is around a year after the repair now, and the tear in the meniscocapsular area, remember, is not there anymore. Yes. Surprisingly enough, even the sutures have disappeared. In spite of having non-absorbable sutures, this is PDS sutures. All the sutures have disappeared. And these are the post-operative radiology. And this is our paper, Long-Term Clinical Outcome of Bone Marrow Augmented Meniscal Repair, key series. We have a number of patients, and we have long-term follow-up, more than 12 years. If you looked at this patient, this is a radial tear, neglected radial tear of the lateral meniscus in a young handball player. And you can imagine how fast are the arthritic changes that had occurred to the surface of the femoral condyle and the tibial plateau. This tear probably won't be easy to repair. But on the other hand side, this is another tear, another radial tear of the posterior horn of the lateral meniscus in a professional gymnast. And when I found the edges rewarding with good vascularization, I did the repair of this tear using outside-in sutures, a combination outside-in sutures and all-inside sutures, to get the edges completely coapted and nicely compressed. And probably because of this, and because the patient had the function of the lateral meniscus there, you will find this after 4 months. So that has been our patient 4 months after radial tear of the lateral meniscus. My only and lonely conclusion is save the meniscus, and thank you for your attention.
Thank you. Can we just speak in English? Because I love saving the meniscus, just so I can understand as well, and then we can have comments. Thank you.
قصدك بعد قد ايه يعني من الانجري. The question is, after how long did we do this surgery from the injury? Time lapse from injury to surgery mean this. This is one of the factors, of course, of having sound environment of meniscal healing. And the shorter the duration is between injury and surgery, the better are the results. That has been around days, 10 days or I think like that, the last one.
I think if you look at our previous dogma, we talked about red on red, red on white, white on white, and don't do the white on white. I do all ages, all areas. As long as it takes a stitch, I'll repair. And my personal failure rate is 8%. So 8% of my patients will fail, 92% will heal, and that's the figures that I give, of all ages. And I don't use the bone marrow aspirate concentrate for no other reason that it's not as easily available. And like I said, some things are easily available over here. But my life for meniscal repairs changed when I learned how to medial pie crust.
Yeah.
Okay, so the first thing you should do for anyone who wants to do arthroscopy is to learn medial pie crusting. Yeah. It takes a little while to learn, and then it's easy. You put needles, 3-4 passes, maybe give yourself 45 seconds to a minute. Sometimes it will take 10 seconds, sometimes it will take a minute. And you've got plenty of people here to teach you, and it's difficult to teach you in a lecture hall. You must medial pie crust, and then you can see the whole of the meniscus, and you don't scratch the condyle. And then you can repair much easier as well, because you can get your sutures from the top, you could get your sutures from the bottom, you can, so medial pie crust is number one most important technique to learn. Second most important technique to learn is switching your portals. Because if you, depending on where the meniscus and how much the meniscus is torn, you can't do it just from your natural portals. You tie it back, and you must be so used to switching portals that will then give you the best results and view. You need to learn how to position the patient depending on the tear you're expecting to find. So if you're going to do a medial meniscus, you want the post high and tight, and you need to get on the other side and do a stress, so ovarian stress. So you need the post tight, and you need to have your portals just above the medial meniscus. So not high and quite lateral, just over to the patellar tendon. You don't injure the patellar tendon, so you can get all around and you can do your meniscal root repairs, you can do your ramp lesions. If you want to do the lateral side, you need to take the post away. So then you do your patellofemoral, you do your medial compartment, check whatever else. Then what you do is you ask the scrub or runner to take the post away, and then suddenly your lateral side will open up. Because otherwise the post stops the lateral side opening up. So those are there's lots of little bits, but it's those things that will make your life much, much easier. So I think rather than getting too worried about the time and whatever, it's how can we deliver the best surgery. The other thing is simple things can help. So if you don't have access to PRP, what I do is use the microfracture awl. Just go to the side of the notch, just where the ACL is, in front of the ACL, knock it, and you'll see little bubbles of fat come out. And then they will find their way to your meniscal, I think it's equivalent of...
it's the same idea, more or less, same idea. You just take some bone marrow out.
Yeah.
So if you do this, probably you will get 1 or 2 centimeters, cubic centimeters. Yeah. If you went to the iliac crest, you probably get a little bit more, but it's basically the same. Get some mesenchymal stromal stem cells around the repair. Yeah, so that's the idea, simply.
Yeah, so if you don't have PRP, you just use that, and then you do it as a last thing, because if you spend 10 minutes then doing more things, you'll wash everything out, and it's the first couple of meals that come out that are the best, that the best ones, because some people will put a shaver and try and suck it out to the thing comes. That just, you'll see the bubbles come. And again, in various talks I've shown the bubbles. And then you drain the fluid and come out. Yeah. And the thing is, you have to be committed to repairing the meniscus. Doing a partial medial meniscectomy, my scope is finished by 9 to 10 minutes, if you're going to do a partial medial meniscectomy. When I started repairing, it used to take me an hour. Now it takes me between 15 and 21 minutes on average for a meniscal repair. Still double the operating time, but there's all those years when I was an hour, I say, oh no, another Mr. Crash is doing a meniscal repair, this is going to take ages. But then it's when you do it, you get better, and then you get easy. And now I can honestly tell you, I repair quicker than I do a good partial meniscectomy. But you have to believe that this is what you're going to do. Any tips from anyone else? What are your other top tips?
One comment about white and red-white. I think I agree totally with you, because I don't like to announce that white now heal. No, this is not the reality. But I think the meniscus has a greater potential to healing than we've ever been thinking before. So I now do believe that many meniscal tears heal by this collection.
Yes. Anyway,
even though
as long as you could put a stitch in.
At least in some of the cases.
Because if you can't put a stitch in, it's so in the periphery, then you should just coblate it back.
Yeah, the collection I showed in the beginning, these have been 4 or 5 cases healing spontaneously. Yes. I've seen just spontaneous healing, even in the white area, by probably formation of a clot or a thing like that. And the biology goes through So the blood clots will be transformed to some kind of fibrocartilage around. So there is a reality about potential healing even for white tears.
And this is a good thing you say about blood clots. So what you do is get a spinal needle and you make little holes in the meniscus to stimulate bleeding.
Yeah, trephination, you say, yeah.
So you just have to believe. And you give the patients, the quoted literature is 14%. So you say to the patient, you have an 86% chance of healing, 14% chance to the world literature. My personal is 8% failure. So in which case you'll need a second operation. The other people never to repair, I'm going to, contradiction's always good. I will never repair a professional athlete. Like a professional footballer, I won't repair the meniscus. I'll take it out. But I'll talk to them, because if they have a big contract and they're out because they have a meniscal injury, they will, if you repair a meniscus, you have your rehab. If that re-tears and they have to have another arthroscopy, that's 2 seasons gone, their value goes down, their transfer and their money goes down, and the club loses a huge amount of money because their players had 2 knee operations in a year. And so, on the whole, if they earn money from their knee playing sports, I'll take the meniscus out. Those are practically the only ones that I take. I'll not take out the meniscus, but I'll do a partial medial meniscectomy. But you talk to them and you say, what do you want? If you want to repair, I'll repair it. But there's a chance that before the next season, it can tear and your next season is out as well. So that's the only caveat. Talk to your patient and make sure they can do the rehab and take the risk.
Yeah, absolutely agree. I think it's all about counseling the professional player.
Yeah.
And if it is on the lateral side, I think I would repair. On the medial side, we will talk, because if we took a repairable meniscal fragment of the medial meniscus out, yes, this player is going to go faster to the field, but on the long run, probably he won't continue at his career for a long time.
No,
so that's another debate.
They only want to get to 30, 35. But, some of these players are now worth 100, 120 million. God knows what Mo Salah is worth now.
Yeah.
So, but then, and they're earning, they get their money, a lot of their money anyway. But if you look at the club has got investment in anywhere between 60 million to 200 million. If the rest of the club say there's a damaged player, that's 200 million might go down to 10 million. The player might not get picked again or might not get another contract. They say, and I had a Turkish footballer that came to me and he said, I don't care, you could do an osteotomy afterwards, but I need to finish my career. Yeah. If you do, and then do partial medial meniscectomy, they'll cope with the pain. Lots of the ones gone to Saudi now, and a few of the older players, I can't name their names, are using the arthrosomid gel.
Are using?
Arthrosomid, the injection,
okay.
The hydrogel, to keep playing. So always counsel them. Always, I never surprise someone with a repair, because for me, what I do is 6 weeks non-weight bearing. Yeah. But when you say non-weight bearing, be careful. When we say non-weight bearing, people go like this because they're toe touch. That's how you non-weight bear or partial weight bear. But then you see in 6 weeks they get fixed flexion of their knee. Because if you say non-weight bear, people normally put this position. So you tell the physio you want flat foot partial weight bearing or non-weight bearing, then they don't get that fixed flexion contraction. Because my patients that when I didn't do this, they all come back. You do their whatever, and they come back with getting that last extension. Because I put them in 6 weeks in this. Although the brace is unlocked.
By the way, you use braces?
Pardon?
You use braces
for all meniscal repairs.
For all meniscal repair.
Not for ACLs, but meniscal repairs. Because
I'm talking about isolated meniscal repairs. You put in brace. Because
of proprioception. So if you get a kid with cerebral palsy and you put them in an all lycra suit, they will walk better. Or you put your hand on their head, they'll walk a bit better because of increased proprioception. So the brace, apart from anything else, gives them good proprioceptive control. And because I like them getting to start using their quads pretty soon. So otherwise they get quads inhibition and lose their quads. So they start physio early, but keep a brace for 6 weeks.
Okay.
But this is individual. I'm not saying, but that's my reason. I think that's another thing, that if you know why you're doing something, and you can speak in a room that I do this because of this, and someone says, well, I do this because of this, and you think actually their reasoning is better, then it's very easy to switch. When you don't know what you're doing, when you don't know why you're doing what you're doing, it's very difficult to defend yourself or change yourself, because you don't know why you're doing it. It's just the way that you've always done it, or you've seen someone do it. So if I say I do this, you must ask me, why do you do it? And if I can't tell you why I do it, then I'm talking rubbish, ignore me. And carry on what you're doing. So everyone should have a why. So from the scrub I use, to the gloves I use, to the prep I use, to the way I drape, to where I put my post, whether I do medial lateral, I know why I do it. I might be wrong, but then someone can say, and my registrar and fellow have a challenge. Every time they start is that your challenge is in the next 6 months or the 1 year you're with me, you have to make me change one of my practices, but with a reason, not because X or Y does it, but because you found a better reason to do it differently. And I've learned so much by my registrars and fellows trying very hard to make me change something, and I change it when they come up with a good reason. So, like I said, I want to change if there's something better. Anything else on meniscus? I think it's important.
I want to ask you about injecting ketorelac and tionoxicam intra-articular. I didn't do it before. I don't have experience about this. So you do it routinely?
I don't.
And why not diclofenac, for example, if you do?
No, I don't. Intra-articularly, the only thing I inject is hyaluronic acid.
Yes, so no non-steroidal injected intra-articular. This I wanted to declare this, so some juniors may.
So, but I'm not saying I'm right. I'm just saying my practice is that I don't inject any non-steroidals. I don't inject any steroid, because most of the patients I'm seeing are younger. I do inject hydrogels, but they cost a lot of money.
Do you use PRP in management of osteoarthritis routinely?
Stage 1.
Stage 1?
Stage 1 or 2 with just a bit of fraying. Then I send them to the radiologist, and they do a monoshot, which is high, which is rich plasma. So leukocyte rich. Leukocyte rich.
Leukocyte. Routinely in grade 1?
Not routinely. Those people
usually grade 1 heals with treatment.
Not routinely. Those people who are active sports people, who then want to get back to sport that season, it acts as a good anti-inflammatory.
What's your concept about steroid in management of osteoarthritis? It is recommended now from the WHO.
I have a completely different talk on this. I don't believe in steroid in knees. Unless something very acute like gout, someone is suddenly in a lot of pain, and you know some people can have a lot of pain, they're elderly, they can't afford anything else, and they come to you and you just want to give them one shot at relief. It may work, it may not work, but it just gives them that little bit of just a few nights sleep, and that's all you could do for them. So out of desperation, I'll give, as long as they haven't had it before, I'll try it once.
As regards, we see many companies here with drugs saying it is for osteoarthritis. I think all of them are without actual benefit for osteoarthritic patient.
I think if it works for the patient, then why not carry on? People say turmeric works, all this thing works. If it works for you, cod liver oil works. There's so much stuff that we don't understand. Drugs that we should say should work don't work in some people. But some people, there's up to 50% placebo effect on for any medication, any treatment. And if someone believes, if someone started taking something and they say, ever since I took this turmeric or magnesium or this zinc, and my knee pain is 50% better, 60% better, if most of my operations with very little intervention got 50, 60% improvement, then I'd take it. So I don't think we should dispel them. If someone believes something is working for them, we should say, yes, so say do it. Say do it. I don't think we have the right to make people not believe in something that they believe in, as long as it's not causing harm. But steroids, I think, causes harm if you get give multiple steroid injections. Sorry, the meniscus is something that I think was important. Sorry, at the back.
Do you prefer weight bearing after root tear repair?
The root tear repairs are the most significant and serious. So I make a tunnel, I fix them in a tunnel, strictly non-weight bearing for 6 weeks. No two ways about it. And I say, this is what's going to happen. If they say, no, we can't do it, I don't repair the root.
How about the range? Do you allow range after having meniscus?
For root repair, 0 to 90. For all of them, 0 to 90. The knee doesn't like less than
0
90.
90?
0 90.
From the first day?
From first day 0 90. Because this is what we were talking about earlier. You could say to someone, fully weight bear 0 90, but if it hurts, they won't do it. You know, we think that if we could work, if you do like a tibial fracture or something like, we say, oh, we're not going to say full weight bearing, but the patient isn't going to full weight bear anyway. You tell the patient to full weight bear, it's too painful. They don't fully weight bear. They will only weight bear when it's comfortable for them, and then that's a good time. But I always say 2 crutches. So they have to have 2 crutches for 6 weeks. They must have 2 crutches for 6 weeks. The root repairs must be non-weight bearing. For me.
I'm asking about the duration of the tear. You make a repair for a tear even it's the incidence is old.
When the tear was.
Whatever the tear.
Whatever. If it's.
I'm asking about the incidence of trauma or the tear.
So, my current waiting list for my urgent patients that I should be doing in 1 month is about 12 to 15 months. So if someone comes with an ACL and meniscal tear and they're not private, I'm repairing them, I'm reconstructing them 1 year to 1.5 years after injury. It's rubbish, but it's how it is. I repair anything that can take a stitch, I will repair. If it can't take a stitch, and what you'll see is the stitch will pull out, then you say, well, what are the options? A meniscal allograft transplant, which is a big operation, or you take that bit out, let them do what they need to do. And if the arthritis stops what they love doing, then you go and you say, okay, we'll deal with that at that stage. But if it can be repaired, and they're prepared for a second operation, soon after the first, if my repair fails, I'll repair it.
When
You said
not to
that
operate on meniscal tear.
So the question is, sorry we're going to run over, but the question is when not to operate on a meniscal tear. Until this month, the standard thinking was only repair the meniscus if there's mechanical symptoms of locking or giving way. If it's not locking or giving way, then don't repair the meniscus. This month in the Bone and Joint has been published a paper by Andrew Metcalf from Coventry that say that even in the absence of mechanical symptoms, if patients have persistent pain, then a partial meniscectomy is, they've just talked about partial meniscectomy, and arthroscopy is useful. For me, what I look at is at the MRI scan. Because in the MRI scan, if the tear shows capsulitis and there's a flip fragment, I'll go in. And because that inflammation is caused by the meniscus. If there's no capsulitis and the patient's asymptomatic, then I won't repair it. So So symptomatic, asymptomatic tear in a young patient, I'll say let's repair it. Symptomatic in an older patient, I'll repair it. Which symptoms to repair by, now I'm going to have to change from yesterday. Before I'd say if there's no locking or giving way, carry on. But now I'll say, well, I'll offer them the scope as of the paper that's been published this month. Does that answer the question? Right, shall we have the next talk and then we could carry on the discussion afterwards?
I think no next talks.
There's me.
Is that
And it's very, very important. It's the physiotherapy after meniscal
but
repair.
actually, you answer a lot of questions, and you go depth in my role by weight bearing and early and everything like that. So you will minimize the time.
I have an appointment for a train, so if
Okay.
anyone wants to ask about my presentation, because I'm obliged to go, Manish, I'm sorry for this.
Okay. So anyone have a question for Dr. Akram?
So that's
Thank you. Thank you very much.
Thank you very much.
دكتور رفيق. Assalamu alaikum. Good evening. I'm away from orthopedic, but I'm a physiotherapy, so I think we are highly cooperative in the success story of every case. And all the questions coming from Dr. Amir, Dr. Akram about the healing process after repair. And I think because we are like the cycle, we have all the outcome from the operation. I think you need to qualify the manner of the meniscal repair, because a lot of athletes we saw in our clinic or our club is suffering of a lot of complication after meniscal repair than those who do meniscectomy. And for this starting issue, we now asking the same question but without any arthroscopic. Maybe some of the doctor asking Dr. Amir about that. So the heel have the chance to heal without any arthroscopic. Actually, related to the old sentences that the meniscus is avascular, aneural, there is some vascularity in the zones of the meniscus. So the meniscus can heal without arthroscopic, but with a special conditioning. In other words, for us at the physiotherapy, because the issue for us, maybe Dr. Amir mentioned some about the spacing and the alignment. So the issue of us in the physiotherapy, how the knee is adapted with the tear of the meniscus. So we have the ability to adapt the knee so no more rotation will go for much degeneration on the meniscus in the running, sprinting, or the athlete's activity, or we don't have the ability to do that. So the tear or losing of the fluid from the meniscus will make it the space is not at the same alignment, and this will hurt the meniscus anymore and produce more pain in the future. The meniscus is different of loading or bearing during the movement according to the angle of the knee joint. So in the full extension, the anterior root more loaded, in the mid-range, the mid portion, and on the full flexion or near full flexion, the posterior horn will be more loaded. In this range, we are considered in our rehabilitation, any part of the tear or degenerative, we minimize the load on the function during rehabilitation of the knee joint. The other thing, again, who cannot do arthroscopic and can be follow the conservative measurement or conservative rehabilitation, it depends on many factors. So symptomatic or non-symptomatic mechanical alignment, aging of the patient, the activity of the patient, so it's professional athletes or not, the tear and the MRI, the amount of the tear, if there is a flab or any degeneration. For degenerative tear, we usually prefer the conservative treatment because the researchers which see the outcome after 5 years for the arthroscopic and non-arthroscopic found the same degree of osteoarthritis can happen on both. And I'm here listen about a lot of biological issue like high reach PRP and some of the injectable. In our field also, we have some of the biological current that can help in the regeneration. It's some of them, so the high intensity laser and low intensity laser with a specific dose can do biological helping in the healing of the meniscus. And what I'm seeing is the meniscus have a wedge-like shape. So if the peripheral surface of the meniscus can be strong enough to keep the spacing and the fluid go and in, like the imbibition, it's actually working with me in the conservative without need to any arthroscopic. So usually in the degenerative, even the mild or moderate, working conservative first for at least 3 to 6 months, and then see if I can success or it can refer again for the surgeon for the surgical option. And one of the famous or golden standard technology which I have seen in about 5 cases already changes in the MRI of the meniscal tear, and it will be spontaneously healed without any arthroscopic, without any medication injection. This is called the nuclear magnetic resonance therapy. And this is because it's very high expensive. So in Egypt, we lose this technology here, but in UK they have, in American they have, in Jordan they have, in some Gulf area they have, and this is depends on the theory of the magnetic resonance, like MRI, but a very low Tesla, and 2 medium column like that. And this, the interruption between the magnetic resonance inside, between the hips, between the knees, make the fluid coming up and through and down through the meniscus, and that help in the gain the healing from the synovial activity of the fluid. Again, some researches is not very strong about the extracorporeal shock wave and the electromagnetic short wave. This is some of our tools which can help for spontaneous healing. For that cases, we are not go for the arthroscopic and will follow the conservative training. Okay, and for this issue, because the main issue for us in rehabilitation is adjust the spacing on the knee joint and control the rotation during movement. Every load happens in the rotational factors can destroy the meniscus at the distortion of the fluid coming a lot and a lot. So we are dependent on a lot of manual therapy to adjust the spacing of the knee joint. And we didn't look for the knee joint itself, but we're looking for the rotation from the hip and the stability from the foot. So if the foot is pronated or supinated, it affects the tibial rotation either internally or externally, and that increase or decrease the varus or valgus. At the same time, also the internal or external rotation of the femur can help in this issue. So we control the rotational from the hip, knee, and foot. And even if the foot, we need to do some external orthotic like insole, we do like that to control the mechanics of the foot during our rehabilitation. The second thing, rather than the spacing, is the control, good controlling of the knee during the rotation. And everyone know that the knee joint, when it coming for full extension, it go for the screw home mechanism, lateral rotation, and when it flexes, it go an internal rotation to unlock this. So the rotation happening in the end of the extension and beyond the 90 degree. And that's controlled very well by a lot of the strengthening exercise specific for the popliteus muscle and the proprioception. So one of the major issue is the proprioception training in the conservative management of the meniscus. Okay, again, this is our goal to keep the grading of the load and the neuromuscular adaptation and control and the patient awareness. And the control of the knee, we are usually use it from simple way and follow the motor learning process. From the cognition, the patient know how to control, then the association, so control it in the hard surface, then smooth surface, then uneven surface, then unilateral, then when do movement like the jumping, landing, and more the skills of the sport athletes. Okay, this is some of the exercise or tips of the exercise. I will show you some videos in this talk. But we starting when we dealing with the meniscus in the conservative or even in the repair with an open chain, not closed like ACL. In ACL, we need to secure the graft, secure the ligament, so we go first for the closed chain, but here we starting with the open chain to help for the distraction and opening of the joint. So we have a control of the muscles. We didn't neglect the hamstring cuff muscles because this is the main controlling of the rotation, hamstring cuff and popliteus muscle, in addition to the quadriceps, who is the primary control. And then some of the exercise, we call it is prohibited or contraindicated if I have a root tear or the posterior horn. It's like, for example, quadriceps hit. So if I have a root injury, I don't ask the patient to please press on the towel or press on my hand because the load coming on the posterior horn. The bridging exercise, if I have a posterior horn or root, I'm not recommended it because usually it's stressing or loading the posterior horn and the root. So some of the exercise will be recommended from the first stage, like mini squatting, like low level impact, proprioception, and isometric. So we are usually follow the mode of the contraction as isometric, then eccentric, because eccentric make an elongation of the muscle to strengthen it in lengthening, so open the joint, and finally the concentric contraction, which make a compression in the joint. And then we can go for these steps: manual therapy, fusion control, lymphatic drain, and then strengthening exercise, by which is a scenario we said, then finally the proprioception and neuromuscular adaptation. Okay, this is some of the exercises we use in the conservative treatment for the meniscus or even after repair. The control of pain of the fusion, muscle activation, range of motion, release, strengthening, stretching, and we usually use some advanced technology like isokinetic with an EMG biofeedback, so the patient can know everything he do. In some athletes, we ask him to play like games in the screen using the knee, so he can do concentric, eccentric, isometric, controlling everything through this gym, and this is a motivation type, and have a long time, he is not boring, and have a score, so he is very motivated to go for the next step easily. And the balance and weight shift, we usually try to use an objective and feedback. This is make a open looped in the rehabilitation, and also make the autonomous stage early. So finally, at the end of the rehabilitation, I need the patient to control his knee without any attention. So like I improve the activity of the brain that allow the patient to control his knee from extra rotation or extra risky movement without thinking about. Like the man who try to typist first, so looking for each letter, then have a long time, but when he repeat and more learning, he can typist when he looking for you without looking for the letter. This is what I'm aim to have from my rehabilitation in the knee joint after we finish the rehabilitation. So a lot of exercise can advance it to the associated learning using unilateral, cognitive, multitask on the balance board, so non-even surface that help in the controlling of the knee later on. And finally, we go for the criteria of safety return to sport with the time of to test the quality and the lower limb index that should be not increased than 10%, and the quality of the movement is very high. And when we testing the isokinetic, we looking for which called the rate of the tension developed, so the patient can develop the tension early, maintain it for a long time. This is the quality that I said you are now success to go for your life, your professional athletes without need for any arthroscopy. One advice from me usually, and some of the orthopedic review that because he told the player usually you don't need, I asked or recommended him to do a routine intra-articular injection like hyaluronic or something to protect the meniscus, because if we have a risk factor and the player I don't sure that he will continue on the strength and learning on someone, so he may be lapsed in some time and make a very load on his knee. So for a protective issue, I usually recommended him to go for a routine intra-articular hyaluronic or something like that. I think this is a doubt point. This is some of the exercise usually happens with the conservative treatment of the meniscus, depends on the early stage or late stage, starting with open, then with closed. You see here the angle of the knee joint. We have a critical angle to be emphasized, so 25 angle and 45 angle is a critical to have the control. And finally, we are measuring him, and if we have a success story, we allow him to return again to his life. Thank you so much for your listening.
Thank you very much. Any questions? Well, thank you for your attention, and it's been a really enjoyable session. My favorite session so far. I've learned a lot, so thank you so much, everyone. Thank you. Thank you. Thank you for all your help. You're welcome. You were brilliant. You're welcome. Thank you. Thank you.